You only have to damage maybe one of these with one molecule of toxin to get an effect. So it really is very powerful to achieve that. And just in case you didn't believe me, here is a human neuromuscular, no, this is an animal neuromuscular junction. Here's the gap. Here's the vesicle that's filled with the acetylcholine. And this is what normally happens. You see they're all docked. Okay, this part here, that's called an active zone. And if you bring toxin in, they've got nowhere to go. Normally and then they go off, and then they recycle. But you see they've got nowhere to go. They all stack up. The nerve is trying desperately to work, but it doesn't actually achieve it. Something else that we're discovering slowly by looking at data.
Sorry,
please.
I always believe that the action is the time that the neuron takes to recreate this nerve complex. Is true or not?
The nerve has a sort of pool, a reserve of these, sitting waiting all the time for a signal. And here, it's bringing in from other places those materials, these other vesicles, to compensate. You believe it was the recycle time.
But yes, I understand. Probably I don't succeed in explaining my concept because my English is so poor.
Oh.
But I believe that the action of the botulinum toxin is to destroy the SNAP25.
Yes.
Okay. And the time that the neuron takes to recreate.
How long does it take?
Okay, the SNAP25 is the time that have my clinical action or not.
No.
No.
Maybe the question is, how long does it take the same synapse to recreate the bridge with the muscle?
We don't know because the toxin keeps breaking it.
But is always the same synapse, or is a closed synapse that goes to the muscle?
What happens is that the toxin comes along and does the damage and keeps doing that, because SNAP25 will be remade all the time. All the time. But the toxin's there all the time. And so it keeps chopping. And it keeps doing that all the time for months on end.
It's fantastic. Because now we are analyzing all the legends. And not the legends. The sprouting exists.
Sprouting. Sprouting.
This point is very important because the duration depends on the time that the botulinum toxin remain inside the cell.
Yes.
Okay. Without being
Going on, I'm sure we will talk about what's about the diffusion.
diffusion.
I'm sure you will explain after
Well,
that.
I'll try, yes.
Oh, you will do, I'm sure. But what's about the diffusion? So different toxin with different diffusions?
No, there aren't.
There are
There's
not.
no evidence at all for that. Zero.
Okay.
Zero. Nil.
So the same
Null
toxin.
point. Null point. No, nothing at all.
So you mentioned this morning the Matteo Caleo work.
Yes.
He used the lab toxin,
Yes.
not the plant toxin.
Yes.
Is it the same? We can compare the toxin or not?
You could compare the toxins, that's okay. He used A1, we use A1, fine. But you can't compare the amount, the quantity. He used a huge
I know it
overdose.
work. I
Yeah.
spoke with him.
Yeah,
But
yeah.
take off the quantity, but the quality of the toxin
No,
is
the
the
quantity.
same.
You need
If
to
he use the
focus.
same quantity of toxin, should he get the same clinical effect?
If he'd used the same quantity of
Yeah.
toxin,
Yeah.
correct quantity, he would not have seen what he sees. He would
yeah,
not have seen it.
Of course. But the lab toxin is quite the same of the,
Yeah, it's just purer.
it's pure.
Yeah.
So the diffusion does not exist.
All
Or may I say
toxins
how
diffuse.
much is the diffusion?
All toxins diffuse,
Yeah.
all of them.
Yes, but
They
how
have
much?
to. But the difference between them doesn't exist.
Yes, but
It's
how
the-
much is
It's the dose that counts.
You don't answer. How much is the diffusion?
It depends on the dose.
No, he's talking about.
Much is the dose, much
Yeah.
is the diffusion.
On the dose or the volume or what?
The dose,
The dose.
the number of units, I'll show
The
you.
number of units.
I'll prove to you.
The volume
No, not necessarily. I showed you volume data, which said no.
volume no.
It doesn't seem, well, maybe not. Maybe not.
You destroyed everything in our minds. Santa Claus exists. No.
But you're just coming back to what you said about the snap being remade and everything. My evidence for that is simple, and I'll try and show you in a minute. But it looks like you cannot kill a nerve with toxin.
No.
You can reduce its activity
No.
to about 20%.
Only 20%.
Yes. You don't kill it, you
Yeah.
reduce its
No.
activity, and it keeps working at 20%.
So if you use 1 million dose of toxin,
I'll show you.
Cannot, yes, you cannot kill. You can only.
But you'll kill because the toxin will then go everywhere, of course.
Yeah.
I mean, as I always say, you can get the best result aesthetically by completely paralysing the patient. They will never have another wrinkle, but they won't be
Okay,
alive.
but what about Frotox that I told this morning?
Oh,
With cold.
yeah,
Can we have 10 minutes?
I wanted to.
Yes.
I'm
thank
getting
you.
very hot.
Yes, thank you.
First of all, we're using it at doses which are so low, it's below the immune threshold of people. Now, of course, different people up and down. But for aesthetic, you're not actually injecting enough to get an immune response. And it's actually pretty difficult. If you take an animal and you try and immunize them against toxin, if you use live toxin in the animal, it's very difficult to get an immune response. Very difficult. So,
For a problem of dose. Only
Yes.
for a problem of dose.
yes.
So if you take people who have botulinum toxin poisoning and they've survived,
Yes.
there you would find a high number of
Yes.
antibodies.
Yes.
Would you say they're immunized?
I would say they're immunized.
They're
Yes.
immunized.
Yes. But I don't think we've ever looked, I don't know of any study that's ever looked at at food poisoning patients,
This one.
10 years later,
Okay.
to see whether they've still got antibodies. And of course, in the therapeutic world, where the doses are much higher and they're much more frequent as well, don't forget frequency is important here. 4 times a year, they would come back every 3 months regularly for maybe 1,000 Dysport, maybe 250 Botox units. That's a lot of material.
Sorry, but if you botulinum toxin remain there and do its action for all the 6 months, for example. So if I do another injection after 4 months, I have an additional effect.
Probably not.
Probably not.
You might make it last a bit longer.
Mm.
Yes, you would probably do that.
Mm.
Push it out
Yeah.
longer.
You give a great importance to the dose. How can you compare that with toxins?
In clinical models.
In clinical models. Clinical, you mean man?
Yep. clinical models. Yeah. Humans, in human patients, yes. Yeah.
The traditional belief that to reduce the risk of immunization, which to you is almost zero, that you shouldn't re-inject before at least 1 month, that's just nonsense.
If you gave the patients the touch-up, a few units here, a few units there,
that's what I mean.
you're using so little material. There's no evidence that that causes any more antibody formation. We always have to, or I certainly have to keep reminding myself, 10 million patients a year, okay, maybe 10 years of treatment a lot of these patients have had, 15 some. If we were going to find problems with the aesthetics now, we would have found them by now. We would have found them years ago. 10 million patients a year is a huge clinical study. We will never get bigger than that.
But let me ask you this, we don't have the possibility of measuring specific antibodies, but I think every one of us has seen a few patients in his career that somehow at one point don't respond anymore.
Yes.
Is that on an immunological basis or is it something else? I have at least 2 or 3 of those patients.
And I think just about every doctor I've ever spoken to has about 1 or 2, 3 patients. Every doctor. And we've counted 20 different reasons why the patient could stop responding. Some of them are product related, but they're unlikely. Some of them are doctor related. Some of them are patient related as well.
Sorry, how do you explain that there is someone that don't respond to the treatment? I have
From the first time?
Yes, the first time. I have only 2 patients that, and I have tried the 3 botulinum toxins available in Italy, and I have no response.
Yeah, I think there are reasons to do with the patient's anatomy and their junctions, and they might have a mutation of a binding protein for toxin. Well, that's possible. They might have antibodies because they've actually had food poisoning in their past, and you can get subclinical food poisoning as well. You can have sort of minor botulism food poisoning, small botulism food poisoning. So I don't think we know enough about humans, people, to say exactly why. It's very rare to find a patient that never responds. Yeah. And then
I have, come si dice scommettere?
Bet
with her. A bet with her. Oh, it's impossible.
Mm-hmm.
She said to me, I am a responder. I've tried the 3 solution.
That's very
She is
rare.
really unresponsive.
Yeah.
I am bad for you.
And me, I have a patient who respond very well in the forehead and in very orbital, nothing. I take the treatment two time, but nothing.
I think this is the first new medicine to look at faces and facial anatomy and how things work and muscles ever. We've never looked at the face in the same way as we're looking at it now. So, to understand why one patient doesn't respond here but does here, it's obviously something different about their junctions here, their muscles here.
I never
Very
saw no
difficult.
responder in aesthetic, but I saw some in hyperhidrosis.
Mm-hmm.
It's more frequent.
And of course, that's a different mechanism.
Yeah.
Hyperhidrosis is a different mechanism. Yeah. No, I think it's we can test for antibodies. We know we have a test available to us for antibodies. Yes. And we tested a patient recently from Australia, and she had all the symptoms of an antibody positive patient.
Yeah.
very short response, very weak response, no difference between the products, all of those things. Okay, so she was the first person in a long time that came along. So we tested a sample, no antibodies.
No antibodies.
No antibodies. This is about sprouting. Now everybody thought you put toxin in, it kills the nerve, the sprouts form, they take over, and that's it. Nah. Doesn't work like that. And the people that said that, they didn't look at this publication here. Okay, so this is an old publication, right? This is from 1990. So this is old in the toxin clinical world. And they took biopsies of the muscle around the eye, the auricularis. They were treating blepharospasm, okay, and they took biopsies to see what was going on. So this is a normal untreated patient. Here's the nerve, here's the nerve, here's the neuromuscular junction. No problem, that's what you'd expect, okay? And here is a treated patient, someone who's been treated for 3 years, okay? And here are all the sprouts, right? But the sprouts don't do anything. There's nothing on the end. You see?
Are not
They're sterile.
unaffected.
They're sterile. They don't do anything. Okay, here's the original junction, but these, look, there's nothing here. They don't do anything.
After this, I need a Prozac.
And I think that they do have some role, they do have some function, because the original
The
junction.
sprout have no time they have no time to be effective, or are
This is true.
effective always.
This is 3 years. This patient has been treated for 3 years. I think it is possible that the sprouts have some role, small role, that they do have some. Some will work, but it's temporary. And we do know from other work in mice that suddenly, with a sprout, there's like a switch, and within a few hours they retract and disappear. Not days or weeks, but a few hours. And that's been done, that's been mapped in mice.
D'altronde se non muore e viene raggiunto soltanto del 20%, lo sprout è praticamente inutile.
We also know this. Okay? This is very interesting because this is in the same muscle but of a rabbit this time. This is before and this is after treatment with toxin. And you can see that it's trying to recover.
Okay.
Trying to recover. The muscle is trying hard to recover. This is, I think, probably two weeks after treatment. So it's trying to recover, but it doesn't, because the toxin keeps working all the time. Keeps working all the time, keeps functioning all the time. Here's something you may not have heard of. That actually these junctions, the targets of toxin, they get old as well. Like everything, we get old. But these junctions get old as well. And if you compare what goes on in mice that are young and old, there is a very, very big difference between what's happening in the junctions. And I think we're seeing for some of the toxin products now, in at least one of the toxin products, there is in the SPC a comment about people below 50 and above 50 years of age. That people above 50 don't respond as well as people below 50 years of age. That's been found for one of the products that's out there now on the market. Let's have a very quick look at anatomy. Let's just, right. So here anatomy is important because we're trying to understand how the face works, we're trying to understand how it functions, and all these different muscles involved here. And, you know, this is the first time this guy here, who discovered about facial anatomy and muscles. And what he did was he took different people, okay, and he put electricity on them, he gave them electric shock, Duchenne. And you can see here the wrinkles that appear when he gave a shock. And he did it to everybody. Look, he made this guy's hair stick up with all the electricity. He did it to a child. And he did it to the lady. He investigated the face, facial muscles. Darwin was the next guy, about 40, 50 years later, to look at the face. And he published this, and of course Darwin was very controversial in his years. And people ignored this. They paid no attention to it. This is a picture that Darwin put in his book about the facial muscles and things. So here's our picture of our corrugator, and here's our picture of our targets on the corrugator here. Now, this has never been published. Never. This is not available. This is in a thesis, a master's thesis, that this guy Craig Goodmurphy published. And he took cadavers and he dissected them, and then he did staining for the junctions. You can do a particular stain for the neuromuscular junctions. And he published this picture in 1996. These are the junctions around the orbicularis. Okay? So they're grouped in different places there. So those two muscles and the DAO are the only ones where we know where the junctions are in the face. We really don't know. There's no pictures of the frontalis. There's no pictures of the procerus. There's no pictures of the zygomatic area, apart from the DAO, where the junctions are. And I definitely would say, if we knew more data about where these junctions were, we could target treatment a lot better, I think. We saw these, I showed these this morning, but the important thing about this is, each one of these is a junction. So every fibre of the human face has a number of junctions on it. All the other muscles in the body have one, but not the face. So let's look at the pharmacology. This is the most important piece of information about pharmacology and how you study pharmacology of toxin. If you just look at this column here, type A, the mouse is not as sensitive as the rat, and the rat is not as sensitive as the human. The most sensitive creature to toxin is humans. So if you do a study in mice, you have to give a lot more toxin than if you do a study in rats. And in rats, you have to give more toxin than you do in humans. And that's a big problem. That's a big problem. Because what it means is that if you study in rats and mice, you're going to end up with the wrong doses. You're going to end up with the wrong numbers. It's a big problem. Here's the different types of toxin.
Is the contrary in the pharmacology, because we talked to the weight of the, we have a weight, the rat has another weight, so it's a contrary.
Okay, that is really good data. And in fact, if you look across, it's the same for type B, it's the same for type C, type E.
Yeah.
Also, toxin gives you different results depending where you inject it, how fast it works. So if you inject it intravenously, you get a different result to if you inject it subcutaneously, for example. And it's all to do with the transport. but this is old data. So, if you're going to do animal work with toxin, and people do a lot of animal work with toxin, it's got to be relevant to humans. Otherwise, there's no point in doing the work. We found some years ago, my colleagues and I, Rod O'Keefe, Steve Dodd in the States, Andy Judge in the States, working at a department in Florida, we developed a very, very good model for measuring, for looking at toxin in animals. Very good model. And this is it. You inject the gastrocnemius muscle of the rat in a very fixed position with a very accurate volume. And then you can measure the force that the muscle has with time. You can watch what happens. And this is what happens. So this is control animals here. This is what happens when you give a very, very small dose. You do get an effect. It's very rapid, but then it goes off very quickly indeed. But just about all the other doses, doesn't matter what dose you use, you always end up at 20% of activity. The leg still moves, it has 20% of the force that it used to have. You can't get it lower. Look, there's nothing down here at all. It's 20%. What you actually do is you make it last longer. So the toxin stays hidden, and the more of it that there is, the more effective it is in lasting a long time. And this is what you end up with. This is the dose response curve for botulinum toxin in the rat. 0.1 of a unit, 0.1, 0.5, 1, 2, 3. What it shows is that after this number, doesn't make any difference. You end up at 20% of the activity. And of course, what will happen out here, you will give so much, it will go to other places in the body, and then it will slowly kill the animal, paralyze the animal. So this is a small window in time. Now, some people have tried to use animals to understand the clinical differences between the products, all right? And this is the curve that they've produced. This is their curve. There's 4 different products on here. Botox, this is pure type A, Dysport, and type B here. And what they've done is they've injected a hind limb of the mouse here, and then when you pick the mouse up, it does this with its legs, and its toes are like this. And the more toxin you give, the more closed the toes are when you pick it up. Okay? So there's no numbers at all. It's like your number 3 is my number 2, and so on.